and the organization you represent into the chat. Um, so today I am very excited to, I'm not going to do it, Stephanie's going to do it, but to roll out the findings and recommendations of our basic screening survey of children in schools throughout Vermont during the 2022-2023 school year. And Tracy Towers is on the call today and is going to be one of the presenters, and she is actually the one that went out and collected this data. So really excited to have her here. And then we're going to hear from a panel of people who are actually involved in doing, for lack of a better word, some of the recommendations that are outlined in the report. So the report has some disappointing findings, but it's definitely not going to be all bad news because we're going to hear about some very inspiring projects. So with that, Stephanie, I'll let you take it away. Oh, one more thing. Presenters, if you could just say a little bit about yourself before you start presenting, that would be great. And Stephanie, I'll let you kick it off. And presenters, just tell me when you want me to advance the slides.
Sounds good. Thank you for that intro, Robin. Welcome, everyone. My name is Stephanie Stead. I'm the data analyst with Office of Oral Health, and I will be presenting findings from this 2022-2023 basic screening survey. And these are the findings that are reported in our Keep Smiling Vermont report that's available on our website and will be linked later in this presentation. Next slide, please. So we know that good oral health in childhood is needed for good oral health and overall health at later stages in life. But we need data to understand population health. Enter the basic screening survey, or the BSS. So what is the BSS? So it's basically a standardized framework for collecting oral health data. So the standardization makes it easy to implement and always consistent. So due to this, it allows us to compare oral health data across states that are using the same methodology, as well as across time. So comparing the current survey data to previous survey data. It involves two basic components. Number one is the direct observation of a child's mouth by a registered dental hygienist. And number two, the collection of demographic information. So specifically, our survey collected oral health data, including active decay, also known as cavities, potentially arrested decay, which are typically cavities treated with silver-diamine fluoride, which is a brush-on liquid that prevents and stops decay. Treated decay, so that includes any fillings that may be present. The presence of sealants, which are a protective coating that go on the permanent molar teeth, as well as the treatment urgency for any sort of dental care needs. As far as demographics go, we collect the grade, gender identity, basic race ethnicity data, and free and reduced meals eligibility data, which is used as a proxy for socioeconomic status. And before we advance the slide, I just want to mention this photo right here is actually one of our registered dental hygienists from the 802 Smiles program. And here she is about to examine a child in one of these nice collapsible pop-up chairs that are really handy for 802 Smiles visits. Make a nice portable dental care unit. Next slide, please. So the most recent BSS, that took place in the 2022-2023 school year. It involved a sample of 32 public elementary schools. There were 1,771 kindergarten and third grade children consenting to participate, and it created one representative sample of Vermont children. So this is representative of geographic regions and socioeconomic statuses across Vermont as a whole. So details about the methodology, the sample, and the limitations of the BSS findings can be found in the full Keep Smiling Vermont report, which, as I mentioned, is available on our website and linked later in this presentation. Next slide, please. So diving into just a few of the findings in that report, the BSS found that over 40% of Vermont's children have experienced tooth decay. Specifically, as you can see on the blue bars here, that's 36% of kindergartners and 48% of third graders. So although Vermont children appear to have less decay than US children, which is shown by the green bars on the slide, these decay rates are still too high. So the previous BSS was conducted in 2016-2017 school year. Unfortunately, the current overall rate of decay experienced among Vermont children is actually significantly higher than it was in that previous survey, which is really indicating that oral health has gotten worse over the past few years. So how can we help? The recommendation that goes along with this finding to address tooth decay more broadly, we'd like to expand early access to primary prevention efforts in medical, dental, and public health settings. So for example, medical dental integration efforts, such as bringing fluoride varnish or silver diamine fluoride into pediatric well-care visits, can be one of the ways that medical dental integration might help address this finding. Next slide, please. So the BSS also found that both overall dental care needs and urgent dental care needs have increased significantly since the last Keep Smiling Vermont survey. So about 1 in 4 of Vermont's children need dental care. And of that 25% that we see here on this blue line, about 18% needed early dental care. That's usually for untreated decay or broken fillings. And 6%, as you can see here by the orange line, those are children that need urgent dental care, and that's usually due to pain or infection. So in the school year when this survey was conducted, there were almost 12,000 kindergarten and third grade children across Vermont. If you think about the fact that 25% of those children needed dental care, that means about 3,000 are in the classroom every day with a cavity. And of those children, over 700 of them are in pain or with an oral infection, which can really affect their ability to concentrate and learn. So the recommendation for this finding to reduce children's dental care needs, we're looking at expanding the 802 Smiles network of school dental health programs and increasing the number of programs that provide dental services on site. So as you may have heard in the past, 802 Smiles program is split into 5 different tiers. And those higher tier programs, typically 3, 4, and 5, are usually the ones providing fluoride varnish, silver diamine fluoride, sealants, and even restorative care at tier 5, which really helps by bringing that care directly to the students in a place where they are most of the year. Next slide, please. So our previous VOHAP meetings have highlighted health equity. So to continue that conversation, we'd really like to highlight this last key finding. So according to the State Health Improvement Plan, health equity exists when all people have a fair and just opportunity to be healthy, especially those who have experienced socioeconomic disadvantage, historical injustice, and other avoidable systemic inequalities that are often associated with social categories of race, gender, ethnicity, social position, sexual orientation, and disability. So that's a quote directly from our State Health Improvement Plan. So the NSLP, the National School Lunch Program, this data shown on this slide, the NSLP is a federally assisted meal program operating in both public and nonprofit schools. So the NSLP provides nutritionally balanced, low cost, or free meals to children every school day. Eligibility for the NSLP is often used as an indicator of socioeconomic status. And as you can see here on the slide, the BSS found that schools with higher proportions of children eligible for the NSLP are more likely to have children with tooth decay. So that's really demonstrated by the orange bars on this slide. Those orange bars are showing the schools that have greater than 50% of the students enrolled in the National School Lunch Program. And you can see on the left side with the decay experience bars, that's 52% in those schools. And of that 52%, there's 34% of those children have untreated decay that should be addressed. And one of the key points to understand with this graph is that those schools with greater than 50% children in the NSLP program, that's statistically different from these schools with much fewer children enrolled in the NSLP program. So basically what I'm saying is that these data suggest that children from lower socioeconomic backgrounds are not receiving the benefit of early preventive services. They're less likely to access dental care for treatment. So Our 802 Smiles network of school dental health programs prioritizes expansion to schools with higher percentages of NSLP students. So we really try to go, all of our actions are based on data in public health, and that's one of the real guiding factors when it comes to expanding 802 Smiles. And we really try to connect with the schools that we don't yet have a presence in, and especially those that might have the highest need. And in addition to that, as I mentioned before, we're also continuing to support efforts towards sustaining higher tier programs that actually bring those services right to the students in their daily life. Next slide, please. So although the full Keep Smiling Vermont report shares more findings and recommendations, today's presentations and talks throughout the panel are going to highlight efforts related to these two key recommendations. So one, as I mentioned before, to address tooth decay more broadly, we want to expand access to primary prevention efforts in medical, dental, and public health settings. And number two, to reduce children's dental care needs, we're hoping to expand the 802 Smiles network of school dental health programs and increase the number of programs that are providing dental services on site. Next slide, please. And so that is it from me. So thank you very much for your time. I encourage you to check out the full Keep Smiling Vermont report to read more about the other findings that were found with this data and the recommendations that we have. And alternatively, if you'd like to spread the word about the importance of children's oral health care, but maybe don't want to share the full report or don't think partners will be reading the full report, we have a nice one-page summary that I think is really great, and it highlights the key findings and a little bit of information about the survey. So if you have any questions, you're more than welcome to reach out to me at the email address shown here. And I'm also happy to answer any questions later during our Q&A. So thank you so much, and I'll turn it back over to Robin.
Thanks, Stephanie. And we will send out these slides afterwards along with the link to the recording. So you will have that. Great. And now I am going to turn things over to Heather Blair. Heather, take it away.
Hi, I'm Heather Blair. I am the co-chair of the dental hygiene, or co-coordinator of the dental hygiene program at the Vermont State University. And as I just get rolling with this, our brief little presentation, this really speaks to having a strong professional network and how things happen because of that, and why these meetings are so important. So about 8 years ago, we started this collaboration with the UVM Children's Hospital, and it all got started with me working in a tooth tutor role in an elementary and middle school, and a nurse that was subbing, and we got to chatting. And it turned out that she was a nurse up at the Children's Hospital, and we, as we were talking, I said, our students don't get a lot of opportunity to see children in our clinic because fortunately, most children in Vermont have the benefit of having coverage through Dr. Dinosaur. And we see a primarily older adult population. And that was it. That was the end of our conversation. A few months later, she called me up and she said, Heather, do you think that we had that really great conversation at school that day, and do you think you would be willing to come up and talk to our nurses about the benefits of oral health care? She said she was on their infection control or infection prevention team at the hospital, and what was recognizing that oral health was being left out of a lot of day-to-day care for inpatients. And I said, sure, I'd love to come up and we can do sort of a little CE with all of the nurses. And then we got to talking a little bit more, and she said, do you think your students would be interested in a rotation up here and actually meeting with all of the inpatient children and their families? And we said, we thought about it for a little bit, and we talked about maybe some of how the logistics could work. And we said, yeah, let's do this. It's not something that was being done in other areas of the country at the time, or we just didn't know about it. We're starting to hear more about this now. But that's when we really started. It took us about a year to sort of plan out what this would look like. But it's how we initiated this collaboration with the UVM Children's Hospital. And it was initially for them to help address infection prevention. It was for our students so that they would get some more experience with pediatric patients. But most importantly, it was for the patients. And let's move to the next slide, please. So when we pitched this to our department, because I was a clinical associate at the time at the hygiene school, I was just a part-timer. I remember going to our program director at the time saying, this is such an amazing opportunity for us to work outside of our traditional clinical setting and have a hygienist be part of a healthcare team. And so that was a pretty easy pitch. There, you know, they jumped on that right away. But when we're talking to students about this, we found that they were a little bit apprehensive about going out of their traditional setting. And we said, you know, if it's not you, then who? Because at the hospital, there's a specialist for everything. You know, if you are a cancer patient, then you have an oncologist. If there's something that comes up with your kidneys while you're on their service, they call in a specialist for that. If there's a pulmonary problem, they call in another specialist, but there's no oral health specialist to call in at the hospital. There are the residents, but they don't come up unless there really is a big problem. So there's nobody kind of looking over the patients on a day-to-day basis. Next. So the Children's Hospital at the University of Vermont is up on Baird 5. It's a 20-bed inpatient pediatric unit, and they see about 2,500 patients a year. And we'll move on, please. There's 325 pediatric intensive care visits a year, but we've really been focusing on the inpatient, just the regular inpatient floor. So when we were talking to students about the benefits of going outside of their traditional setting, you know, our dental hygiene students have 3 years of dental hygiene education. And that education starts with, oral anatomy and then embryology and clinic, and they have pharmacology and oral pathology and all of these different classes that are part of their curriculum. But we typically are in our own little clinic, and we don't get to see some of these outside things that they may see in clinical practice when they get there. So just having that increase in medical knowledge as a healthcare provider, you know, the dental hygienist really is the primary prevention specialist in the clinical setting, whether it's a private office or a public health setting. They're the disease prevention and maintenance specialist. And then the dentist that they work with is the restorative specialist. They are the ones that are the architect, engineer, and artist and can build something out of nothing, but they don't spend 3 years just focusing on disease prevention. So in addition to increasing their knowledge as a healthcare provider, our students are increasing their knowledge in pharmacology. It helps build their confidence going outside of the clinic and actually kind of going into a room cold and not having the patient really be expecting you. It prepares them for direct access settings, and that is one of the directions that we're hoping to go in the future is where people are. We're seeing that there's more and more need for that. They are able to practice their motivational interviewing skills, which is a tough skill to develop. And sometimes when you're under that pressure of only having an hour of visit to do things in a clinical setting, you don't always have time to develop that. They are working on improving their communication skills, improved observation skills. Just being able to read the body language sometimes of the people that you're working with is something that is really important. Challenging their imagination. kids will make you challenge your imagination, because they will call you out on things and they will make you accountable. And sometimes it's really challenging to engage them. Improving teamwork, and teamwork across the oral health networks, but also we're working with nurses, speech and language pathologists, the medical residents. Sometimes we're calling in dental residents. Sometimes we're calling in pediatric specialists, pediatricians to come do consults. They're practicing empathy with patients that they work with, and really working on skills to overcome barriers that families face, whether it's that they don't have dental insurance or they don't have a dentist that is near them, and just helping them work through some of those things. Next. So we see the Children's Hospital sees children that age from about 1 day of life through 18 years old. Once in a while, we'll get a patient that's a little bit older if their census is low. We are seeing patients that are requiring all kinds of different procedures. Baird 5 is a locked unit. Their nurses are assigned usually 4 patients. And so we sort of divide the patients up on the floor with the students, depending on how many patients there are students. But we see everybody that's on the floor, unless it's something that's highly contagious that could be a concern for our students. And then we try to work with the residents that are there. And the residents are on the floor 24/7. Next. The most common diagnoses that we are seeing with patients that we're working with, a lot of respiratory illness, whether it's asthma, RSV, pneumonia. There's a lot of pneumonia this year. A lot of cancers, different pediatric cancers, eating disorders, mental health problems, failure to thrive in young children, patients that have just had surgery, a lot of seizure observations, and then a lot of infections. So we get the acute and then the chronically ill. We try next, as we're working with patients up there and their families, we're trying to direct them to our local community resources. So if there is a family that may be living rurally and they have well water, we're sharing well water test forms with them so that they can assess the level of fluoride that they have, and then make that decision with their pediatrician or their dentist as to whether supplementation would be appropriate. We try to share lists of dentists, although they're updated not as often as they need to be. We are doing oral health screenings, and we are actually using the oral health screening form that was developed by the nurse practitioner at Central Vermont Hospital, I believe. And we're sharing the maternal child health types of oral health brochures and going through them with families. So not only are we going through it with them, but then they have it as a resource and something to refer to once they've left the hospital. We're directing them to either the UVM residency program if they have restorative needs, or we're inviting them for just preventative needs to come to the clinic if they don't have a dental home, and it's surprising how many don't. Talking to them about Dr. Dinosaur, although they've got great social workers up there to do that, but sometimes they don't know that that's even a benefit that they have under that insurance. And we'll move to the next slide. And, I always tell our students, we're better together. A dental hygienist is an important part of any healthcare team because they're the disease prevention and maintenance specialist. And in the hospital setting, they've got specialists for everything. It's surprising to me that this hasn't caught on before now, but it is a great way to address this. Over the course of our time, and I will wrap up in the next minute, we've had the opportunity to present to the pediatric grand rounds. And just this last year, we did the pediatric resident rounds, and we're already on their schedule for next year. So we're making progress, little baby steps at a time. And that's it.
Robin, you're muted.
Thanks, Heather. It's great to see the key recommendations in the screening report really coming to life through these examples. And now I'm going to turn things over to Jessica LeClaire and Dory Myers to talk about expanding access to care in school settings.
Great. And I haven't seen Dory, but she may have joined because there were a few people who joined by phone, and Dory may be one of them. But I'm going to get started, and when we get to Dory's part, we'll find out if she's here, and then we'll go from there. So good afternoon. My name is Jess LeClaire. I am a school liaison out of the Burlington District Office of the Vermont Department of Health. And today I'm going to talk with you for a few minutes about my experience growing 802 Smiles programming in Chittenden County. And again, I'm co-presenting with Dory Myers, who's the district lead nurse at Milton Town School District, and she's going to talk in more detail about their growing program. Next, please. So when I first started, which was around the time of the slide, fiscal year 2022, there were some pre-existing what was then called the Tooth Tutor program at 2 of the school districts within Chittenden County. We have 8 school districts. So Burlington and Winooski both had existing programs, and they both have a really interesting setup where Burlington has a dental suite inside one of the schools, and they arrange transportation to and from that school, and they use their 802 hygienists to screen kids and get them in. Basically, it helps set them up with dental homes and also get them in for treatment as they need. And then Winooski has a similar sort of a setup with a dental suite. I don't think it was as fancy back when I started in 2022, but they have a very nice suite now and an excellent hygienist there who also does similar work, connecting kids with dental homes and doing a lot of work there in the school. So during this year, while getting oriented to my position, I learned more about the transition from the Tooth Tutor program to 802 Smiles and also about the dental need in our community. And of course, 802 Smiles is just a part of my work. So I was working COVID clinics, introducing myself to community partners, and just learning more about how we can collaborate together in general with both public and independent schools at that time. And I did have weekly meetings with nurse leaders in schools and also worked on a long-term health needs assessment project with Essex Westford School District during this time. That's going to be relevant a little bit later in the slides. We can go to the next one, please. So in order to get to talk about 802 Smiles, I actually have a different slide showing, but this was the correct one. So here we go. So we need to be able to communicate with our school partners about how 802 Smiles will help them achieve their goals. And to do that, we have to be able to connect the dots between what's important to schools and what's important to us and 802 Smiles for kids. So because schools are full of caring people who want the best for their students, but first and foremost, they're an institution of learning. They have limited staff, limited funding, and they need to prioritize education. So the first step is to share information on oral health in their district with them. School nurses are often the best places to get that information as they keep track of nurse visits, and they also complete a school nurse report every year that asks some questions about dental homes and dental care. And they also connect students with medical dental homes if they don't have access, so they're often very familiar with the barriers. Knowing the difficulty finding dental practices willing to take students with Medicaid and being able to gather information on percentage of students with Medicaid insurance can also be helpful. So once you've established that there's a dental need, you need to be able to link that unmet need with students not being able to focus on learning. So starting with poor oral health. Students in pain can't focus on learning. Some have disruptive behavior in the classroom that can impact other students' ability to learn as well. They're also more likely to be absent from school. Unmet dental needs and under-controlled asthma are the top 2 physical health reasons that students miss school. And chronic absenteeism is extremely high. And when students miss a lot of school, they're more at risk for poor academic outcomes, which leads to the school performing poorly on their testing and can also possibly increase the school dropout rate as well. So school performance on those measures is assessed and is part of their learning related focus. So if you can connect those dots, that's very important in order to get buy-in. 802 Smiles can help schools help more students get their academic success. But in order to connect the dots, you need an opportunity to connect with decision makers. Next slide, please. So MAC is one way to get that access. So MAC stands for Medicaid Administrative Claiming. It's a reimbursement program. And every year school liaisons hold MAC meetings with school districts. Schools get reimbursement funds through Medicaid for certain services they provide connecting students with healthcare. And those reimbursements can be spent to benefit student health and wellness, and the spending of those funds must be approved through the health department. Due to the state of emergency, when I was first hired, school districts were allowed to suspend their meetings for that year if they chose. So I didn't necessarily get to meet with them and just continue with their previous year's funding priorities without a meeting. But fortunately, some of my districts opted to meet virtually that year, including Milton Town School District. So in March of 2022, we held our first of 2 MAC meetings to discuss how to use those funds. And that meeting included the superintendent, a co-principal of the high school, the grants manager, the elementary school principal, and the elementary school nurse, as well as, of course, Dory, who was his nurse leader and was really the one running the meeting. And we discussed several health and wellness related needs. I'm going to let Dory talk a little bit more specifically about Milton now, and I will come back to you in just a few. So next slide, Dory, or Robin. And if Dory's not here, I'm willing to talk about this, and it looks like she's not. So I'm going to just continue. She may have gotten called away because she is working at the school today. They have limited amount of nurses, so she could be with someone. So I don't have notes, but I know a bit about this, so I'll talk a little bit. So basically, why did they want 802 Smiles in Milton? They'd seen an increase in nursing dental visits with an increase in pain management. And they also were not able to get kids connected with dental homes or get them into appointments in a timely way. There's was a decrease in local providers accepting Medicaid. There's actually there were no providers within 15 miles of the school that accepted Medicaid. And Dory had a story to share, but I don't know what her story was. So unfortunately, I won't be sharing that. So moving into this slide, this is what Dory put this together. It's a little different than what I had. I can talk a little bit about what Dory has here. Basically, the first year of the rollout, initially we had talked about rolling out like a tier 3 sort of setup, but we ended up really mostly being able to offer fluoride varnish and also help connect kids with dental homes. The school felt like they weren't quite ready to jump fully into doing everything there. And they also were able to find some challenges, getting students to agree, their families to agree to have their students looked at was challenging in the very beginning. There were people who were concerned about money being spent on this when everything's so tight, not understanding that this money was actually not coming out of the regular school budget, but a special program. So Dory ended up putting together a video that explained 802 Smiles. And since then, you actually have one on your website now so that people can watch a video that schools could even link to on their own websites. But at that time, that didn't exist yet, and Dory made one. Catherine ended up doing a lot of outreach. She did a lot of classroom visits to build relationships with the teachers and the students. And then she sent home the enrollment form so kids could come home saying like, I don't want to get my teeth looked at. And that helped with that. We added QR codes so that parents could then sign, just look at the QR code and be able to hop down there. You can see for 23 to 24, they made it easier to opt into the program. They attached it to the health form at the beginning of the school year. I'm not quite sure some of the other things in here, but they did add SDF services, which is great. And they expanded their dental education and to all elementary students and not just like the ones where we started off with screening. And they expanded their dental education to include high school students. there were, like the first year, I know they were able to screen 26% of their first graders, and 19% of the second graders, and they saw 10 students in other grades that were referred by the nurses, 9 of whom were referred by nursing for suspected oral health care issues. So they screened 53 students in total on that first year, and 20 of them had not seen a dentist in the past year. Catherine, our 802 hygienist, found 31 decayed teeth, and only 14 of the 52 students who were eligible for 6-year sealants had them. And in the referral group, only 1 in the 9 students who were age eligible had 6-year molar sealants, but none of the 3 students who were old enough to have had 12-year molar sealants had them. And 8 students did receive fluoride varnish from 802 Smiles during that time. We can go to the next slide. So again, she kind of talks about some of that. So they found, this is what they've collected for 23 to 24, that 49% of the students they screened did need a referral to a dental home that would accept state insurance or provide a sliding scale for no insurance. So that's a challenge in the district. 86% of the students who didn't have a dental home were candidates for school-based sealants, and 36.8% of all students screened were candidates for SDF. And then again, that was their secondary and tertiary prevention. For primary prevention, they did do a lot of direct dental education, both for the elementary and the high school populations. And we can move to the next slide. So some of the challenges they faced, it was, again, I kind of alluded to it earlier, the position, or the tooth tutor's position, was MAC funded, but there was a lack of understanding from the community on the purpose of this position and how it was funded. And at a time when, the district had a lot of unmet needs, they were like, how did we decide to prioritize oral health, not understanding that it wasn't like it was this, or we were going to have another literacy teacher. Like, that isn't how that money was being spent. Getting folks enrolled into the program, finding an appropriate space, getting some equipment, and most recently, having difficulty getting their budgets passed are some of the challenges they faced. We can flip to the next slide, because this is actually really nice. It's a little impact story that I can share with you. I know you can all read it, but since we're in a meeting, I'll read it aloud. One of the other, I think it was I think it might have been one of the principals who wrote this, but it was a staff member at the school. I wanted to let you know how much I appreciate Catherine and the 802 Smiles program. She was able to come in on a Tuesday last week to see one of our preschoolers. So Catherine's typical day is Wednesday, so she had not had an opportunity to see those preschoolers. I brought a student to her as I was very concerned about the condition of his teeth. He had been asking for Tylenol several times a week for months due to mouth pain. Catherine was able to contact his family to get permission to screen him. We had been unsuccessful in getting paperwork back from them. She remained in contact with the family throughout the day, completing all the paperwork for an emergency dentist visit. And once the paperwork was returned, Catherine hand-delivered it to the emergency dentist and was able to get an appointment for them the next day. He was seen on Friday and has a care plan in place. He should have surgery this summer and hopefully come back in the fall with a pain-free mouth. I was super impressed at Catherine's determination and speed in helping the student. This program is wonderful, and I hope we are able to, they get a grant, it's not a grant, but that's okay, for it to continue next year. So this kind of just shows an impact for one preschooler, and you can imagine how being in that kind of pain impacts a child's ability to learn and to grow and to participate in preschool, and how that lack of ability to progress in preschool can kind of follow you all the way through school. And so how important it is that this work gets done. Here's the team. So there's a picture of Dory, Catherine, and I. I'm going to continue on now with the rest. We have just a few more slides to share. So where I left off was talking about FY 2023, where we had added Milton, but now I'm picking up with planning for FY 2024. And for the next round of MAC meetings, I had information from the Essex Westward Health Needs Assessment. So in that district, we found that 1 in 5 oldest children are not on the recommended schedule for routine dental care. almost 1 in 2 we did oldest children because we didn't want to, it made it easier for surveying. So we just did oldest children of each family that was asked. So almost 1 in 2 oldest children of respondents who used interpreters are not on the recommended schedule for routine dental care. So it was even more of a challenge for folks who have to use interpreters to access care, to get that care. And 8 of the 13 district nurses reported dealing with dental problems regularly. And a third of the nurses with preschool, elementary, and middle school populations reported dental health as a huge area of concern. So both parent, caregivers, and school nurses reported challenges finding dental offices who would take children with Medicaid. And for some people with insurance, dental care was also cost prohibitive. While it appeared that getting dental needs met was not a concern for all, it was a challenge for some members of the school community, in particular the low income and new American students. So throughout the schools in Essex Westford, I think the lowest amount of students on Medicaid, the percentage is like a little over 24% in 1 or 2 of the schools, and at the highest range, it's a little over 36%. So this isn't the majority of the kids, but there are a lot of kids, and 24% of that, of any of these schools, is still a lot of kids. And again, it goes up to 36 in some. So there was still a lot of need. You can see some of the quotes I hope you were able to look at while I was talking. So I wasn't going to read them all to you, but these are a few of the quotes from the school nurses and a few from the parents that we got out of that needs assessment. So of course, we shared that needs assessment with the school, and they decided that they were going to join Milton in offering 802 Smiles. Milton felt the program was beneficial, and so they increased their MAC funding. And another district that was experiencing pockets of significant dental need, kind of similar to Essex Westford, was also very interested in partnering, but they really didn't have much of their MAC funding that they were able to move from what they were already prioritizing. So we came up with a plan for a smaller scale rollout for them. And then, oh, I'm
Just-
sorry, you
we're
can
running
change
just-
the slides. I
Okay.
forgot to tell you to change for the last 2.
Oh, okay, good. We're just running a little bit behind too.
Oh, okay, I'm sorry. Well, I
That's
can
okay.
just wrap it up. So the next slide, I won't discuss how we got there. We can move to the one after it. There were some budget failures, tough decisions that had to be made, and we were concerned we may not have 802 Smiles in all of these schools for the next year. And if you flip to the very next slide, fortunately, all of our school districts that did establish it, the one of the 2 that I just called the new adopter was unable to get established, so I won't go into that one. But we did get it in all of these, so we basically doubled our 802 Smiles in just a few years, and they are continuing to grow. Last slide. And that is the end of my portion of the presentation. Sorry for going a little bit over.
Oh, that's fine. Thanks so much, Jess. Really appreciate that. I think I'm going to switch the order of things a little bit and have Tracy go next, just because I know Tracy has a time limit. So Tracy doesn't have a slideshow, so I'm going to stop sharing. And Tracy, please take it away. Tracy is going to talk about a project to incorporate oral health into a medical home.
Yes. So hi, everybody. My name is Tracy Towers. I am an 802 Smiles dental hygienist. I am also working with Head Start as a dental case manager and work with Heather part-time at the Vermont Tech Dental Hygiene School with the students. Also, my 802 Smiles role is in the Winooski School District, which is just a beautiful facility now. And I am seeing kids really 2 full days a week for cleaning, sealants, fluoride, SDF, and also coordinating a school transportation program down to Community Health Center, which has acquired Vermont Dental Care. So Vermont Dental Care is now Winooski Dental Community Health Center. So we have a program which has been great for Winooski. Robin wanted me to talk today about a project that I've been involved with, a grant project that has been funded through the Center for Advancing Rural Health and Equity through Dartmouth-Hitchcock in partnership with the Vermont Department of Health and others. And that the goal of that project was to implement and train pediatricians in the use of silver diamine fluoride as part of primary pediatric care. So it's totally new for me to do this. It's been really exciting. I'm working with we have a coordinator for the grant who has been reaching out to different pediatric practices in Vermont and New Hampshire. And we've done 2 trainings, 2 offices so far, and they've gone really well. We did Mount Ascutney and Ottaquechee Health Center. We completed, that was the first training we did in February. The training has consisted of sort of a 2-part. The first part, both are on site. The first part is about an hour-and-a-half PowerPoint didactic presentation about really just introducing them to what SDF is, why it works, how it works, just the history of SDF, and giving them just that background knowledge and information, because many of them have not heard of it. So just that introduction and giving them a really good foundation about what it is and how magical it can be. The second training is a hands-on training that I go back for, usually a week or 2 later, and bring some Typodont teeth that have been prepped with very small preps that would be similar to areas that they would be seeing for childhood caries, class 5s along anterior teeth, as well as class 1s and posterior molars. In the didactic portion, PowerPoint, I really do show them a variety of stages of decay, just to, sort of acclimate them and help them to decide when it's going to be appropriate to place SDF. But the hands-on training is really, it's really been well received, and they're really excited about it because they're so intimidated about SDF, and they're so intimidated about the mouth because everything medical and dental has been so separate that for them to start doing treatment inside the mouth, they're so intimidated by it. So I think just breaking through that barrier of having them sit down at the table with me, and I have SDF and I have cotton rolls and the micro brushes and the prep teeth, and we follow up with a fluoride varnish, and I just walk them through it step by step. They're really relieved that that they can do something that has the potential to have such a big impact, and I've been really encouraged about that. The practices that we've done so far are just champions of pediatric oral health as well, and have been really excited to start. At the Mount Ascutney Ottaquechee Health Center practice, we had some residents, medical residents, sit in on my training, and they were just bright and beautiful and interested and engaged and so excited about it. So that got me really excited because they obviously are the future of primary pediatric care. Upper Valley Pediatrics in Bradford also really excited about the training and getting started. There are some barriers not barriers, but some challenges to implementing it, especially with the bigger organizations like the Dartmouth-Hitchcock system, because they have to go through a lot of red tape, for lack of a better word, to implement policy and procedure and protocol about step by step, how are we going to implement this? And there's a lot of approvals that need to happen, consent forms, logistics, legalities. So they haven't completely rolled it out yet, but they have really they have really they have established a protocol, a written protocol that is pending approval, and they're very excited to be starting that. Upper Valley Pediatrics is not associated with any large organization. And so they are sort of a one-man show, one-woman show, 3 women pediatricians down there, actually, just fantastic, who are just really ready to go. I have yet to hear whether they have actually placed it, but for our hands-on training, they actually had one of their receptionist children who had decay come in and be my model, be my patient. And so it was just really worthwhile. I think anytime that you can just do it live on a child, and I sort of had to coax the child a little bit, and so it was a really real event. So they got to see how that works too. A lot of you are smiling because we have to coax children to do all sorts of things, and SDF is one of them. So that's been really exciting. And because of those 2 practices, we have 2 more. I'm just glancing over here because I had written some notes. We're going to be doing a White River family practice in June and July, and Porter Pediatric Primary Care has just come on too with some interest. And I just got an email this morning from Greg Norman, who is our partner at Dartmouth Hitchcock, who is looking at expanding the grant funding because of the continued interest, the increased interest in the past month of pediatric practices. So that is also exciting. So like I said, it's just been a learning curve. It has not been met with any resistance. The offices that have wanted to come on, they haven't been forced. I'm not walking into an office that is not interested. They care about their little kids as much as we care about ours. And really, I'm hoping that my enthusiasm and our enthusiasm in the dental world for SDF really comes across, and that they can really make a difference. And I think that's what they've been most excited about, that they can make a huge difference right away. And so they're equally as excited about it. So that has been my most recent fun, thanks to Robin.
Thanks, Tracy.
Yeah.
You're all over the place. You did the basic screening survey. You're the you're the 802 Smiles hygienist in Winooski that Jess mentioned, and you're also doing this Carhi project. So great for you.
It's great. It's a great place to be right now.
Thank you. Okay, so we've heard about expanding access to dental care for kids in hospitals, schools, medical practices, and now Kim's going to talk about bringing care to kids in Head Start. Kim? You're on mute, Kim.
Thank you. So I was originally a tooth tutor back in the day, or like 19 years ago. I think I sat next to Robin at a meeting, and that's how I ended up in this position. She sold me, and I still believe strongly in it. So I work in several different locations, but I work for Capstone Head Start and Early Head Start, and for NECA Head Start and Early Head Start in Lamoille County and in Hardwick, Albany, North Troy, Newport, kind of all over the place. I love it. It's very important to me. I so appreciate how much Head Start supports the entire family with so many things, not just preschool. It's so much more than that. So a home visit, when I connect with a family and they invite me to come to their home, I can meet them inside of their home. Sometimes if they're not comfortable, some people have a lot of anxiety about people coming in, especially after COVID. So I can meet them at the center, but it's still a one-on-one situation. It's the parent and me and the child. I can bring SDF and fluoride and screening materials all with me, so I can do that there. I always bring them information. I do an updated dental provider list every few months. I go through and see what local offices are accepting Medicaid and who is accepting patients and Medicaid, which is frequently not a really large amount of people. I bring them handouts like Heather was talking about, I think, that she was sending home about, maternal and child oral health care. Eruption charts, they think those are fun also. And in 2010, I don't know how I ended up doing it, I somehow did a baby oral health program. And so I went into a whole bunch of dental offices and was talking to dentists about seeing kids under the age of 3, because that was still a big issue at that point. And from that, I made a top 10 list. And so I always give that, especially to new parents or expectant moms. So it's just a top 10 list of things that I think are the most important informations to hold on to. I do oral health education, nutrition. I always bring goodies for families. So like toothbrushes for everyone in the household. I can go with families to appointments. Bring them the well water test kits also, or test paper, and arrange transportation. But by far the most important thing of all of those things is the relationship you build with families. Like it's life-changing, really. For example, I have a mom that I went on a home visit when her kids were born, I don't know, probably 15 years ago, maybe 12 years ago. And her life did some things, and she's in a different area, but I actually, through a program I was working with Northern Counties doing an in-school dental program, I found one of her children, and she would not communicate with anyone. Like, she would not talk to administrators or teachers or school nurses. She just didn't like any of them. But when I reached out to her because of my past relationship, she actually signed her kids up. So that was very exciting. There's another one of those kids that is now 18 and a senior in high school that I went to see when he was an infant. And if there's ever a problem in that family, the mom reaches out to me too. There was a first grader that was not part of the school dental program, but I was in the school, and she came up to me and kept telling me that she was in a lot of pain. So I had her mom bring her to my house, and she did, and I got her in. She actually had exposed pulp. So I can't imagine how much pain she was in. And then just on Friday, over the course of the last week, I was informed about a 3-year-old that in one of the Head Start classrooms that had, the mom said an adult tooth coming in, but actually it was 2 abscesses that the child had. And so I got them into a dental appointment like quickly as soon as I saw it. And a lot of things happened in between. The child did start antibiotics, thank God, but the parents they're not very proactive, and they weren't going to give the kid the antibiotics. And so the teachers were very concerned, obviously. And I tried to talk to them, and they were very heated. But it turns out when the mother's mom called me, the grandmother called me, I knew her from before. So she talked them down and got him care. So amazing. During COVID, it was very different. And we did, I think, just like this meeting is an example of it, we just have found new skills, like new tools we can use to meet differently. And so that was Zooms and emails and text messages. I could drop supplies off for the family at their door if I couldn't go in, and outdoor visits. But I also started making oral health videos for Head Start because I wasn't able to go into the home. So that was a lot of things that I would have done in the classroom and also on home visits. Yes, anyway, so those are the things that I wanted to talk about. I treasure my relationships with all these people. It's pretty great.
Thank you so much, Kim. I think your stories really highlight the importance of your relationships with the families and also with the local dental providers. It's obvious that you've established some great relationships, and when you call and say this child really needs to be seen, you're able to make those appointments. And I think that's a real testament to the strong relationships that you've built. So many thanks to all of you. This wraps up the presentation portion, and now we're going to open up the floor for questions. We do have one question in the chat for Heather, so I'll start off with that one, and then feel free to unmute yourself and ask questions of the presenters. Nate asks, do the students provide anticipatory guidance related to establishing a dental home and by age 1 for younger kids? Do they help navigating to identify these? Do they go through the Medicaid dental benefit with families? And that's for you, Heather.
So yes, they do. A lot of, so the goal is once they go in the room, they have to go through all of, a bunch of questions, do they have a dental home? When was their last visit? How are their teeth feeling? Do they have anything that hurts? And then they do their screening. And after they do their screening, they hope that they'll be able to engage the child in some oral hygiene instructions, some brushing, some flossing if it's appropriate. And I say if it's appropriate because kids that are neutropenic, we're not having them floss and, or if they're thrombocytopenic, we don't want them flossing right now. But definitely they need to be brushing. And then we have a conversation with the child, but the parents, depending on how old the child is, about, their do they have a dental home for themselves? Do they have a dental home for their child? If they're under age 1, the importance of that age 1 visit. We go through all of the things. They're usually in the room for 20 to 30 minutes. And then if they've identified needs, then we will talk to their specific nurse, but usually it ends up with us down talking to the dental residents and sometimes actually calling a pediodontist up for a consult. So yes, we are doing those things. They don't go through all of the dental benefits with a family, only what's appropriate. So if it's a child under 1, then we're talking about the age 1 visit and things like that. If it's a child that is maybe playing sports and things like that, and they are seeing a dentist and we know they've got Dr. Dinosaur, then we're talking to them about maybe a sports mouth guard that they might want to inquire about. But it all depends on where they are in there and what they're in there for.
Thanks, Heather. Does anybody else have any questions for anyone?
I love the idea of everything that Heather and Tracy both presented. And Tracy, Heather, if I was closer to UVM, I would totally jump into that with you. And Tracy, that makes me so badly want to seek out places around here. Not that I need more things to do at this point, but I can see that being such a tremendous service.
Well, Kim, if you can think of any offices, then our grant coordinator will do all the outreach. If you have a pediatric practice that you feel would be open to getting some information, please just email me and I will help connect the grant coordinator.
Awesome. I definitely have one in mind.
Okay, I've counted to 8 and nobody has another question, so I think that's the rule. I think everyone probably just wants to get outside. It's so beautiful out there. But before we do that, are there any updates? Oh, Stephanie, did you have your hand up?
Yeah, I just sorry. I'm always the data person, but I just want to take a moment and say I really, really appreciate hearing from all the panelists. And I think that that's such a wonderful part of this meeting is to hear those, the human to human connections and uh, you know, all these personal stories about the work that's going on. It really brings the data to light in terms of, you know, I always say there's so much more to data than just the numbers. And every single one of these numbers that we talk about, there's a person and a story behind all of them. And I think that all your presentations really highlighted that. So just thank you all. And yeah, this has been really great.
Yeah, that's really well said, Stephanie. Thanks for saying that. Susan?
Find my microphone.
Mhm.
Hi, everyone. My name is Susan Coburn. I'm with our Medicaid program and Medicaid policy and work a lot on dental and partner with Robin and others and echo other sentiments. Thank you for all you're doing in the community and getting access for children. I think folks are aware, but on the Medicaid side, we had a couple significant changes in the past year. Well, it's been close to a year now, but one of which was to raise the Medicaid rates by almost 50%. So we know often a barrier to receiving more Medicaid members can be the rates, and that was quite an increase for providers. So hopefully that helps a little bit with practices being able to receive more Medicaid beneficiaries. We also have staff within Medicaid in the department who can help you to find access and really appreciate all you're doing on the ground. You probably know your dentist well, so having those personal relationships is great. And I think you're also all aware that the eligibility for pregnant individuals, the postpartum eligibility was expanded from 2 months postpartum to 12 months. And so pregnant individuals also have the full dental benefit. There's no annual cap, and they have access to services under Medicaid coverage for a full year after postpartum. So want to make sure you are aware of those changes. They've been in place for a little bit. And then two others that we had, which don't impact children as much, but for adults, is that adults who are in our waiver programs who have significant disabilities or, mental health or physical disabilities or developmental disabilities, the waiver programs have access to dental services without an annual cap. So the $1,500 cap on expenditures doesn't apply to people who are in those waiver groups. And they also have denture coverage. And I should have mentioned the pregnant individuals also have denture coverage and no cap. So it's similar to the children's benefit. So we hope that these changes will increase access and expansion, and feel free to reach out if you have any questions on coverage, but really appreciate everything you're doing in the community.
Thanks, Susan. Yeah, all those updates make me think about our state oral health plan, and quite a few of those changes were mentioned as goals in the state oral health plan. And we always talked about that being a plan that we didn't create just to sit on a shelf. So it's great to hear about things are actually happening. I mean, we started off by hearing from Stephanie about kind of how we've gone backwards a little bit in terms of our children's oral health indicators, but there's so much good stuff going on, and it's important to remember that as well. Any other updates from BOHAP members? Stephanie.
Yeah, I just wanted to highlight a positive thing out in the world. I went to the Vermont State University graduation yesterday for my husband just earned his associates in nursing, which I'm very proud of. But I just wanted to highlight that there was over a dozen bachelor's dental hygienist students graduating and a few dozen, I think it was probably 3 dozen associates dental hygienist students graduating. And it was just really great to see a lot of them from Vermont. I'm really hoping a lot of them stick around, but it's kind of
Awesome.
shout out into Vermont for all of them.
Heather.
We had 34
Wow.
graduating dental hygiene students with their associate's degree. Most of them are Vermonters, so I think we're only going to lose a few. unfortunately though, with our bachelor students, most of them are out-of-staters. So, but with the AS students, I think we're going to hold on to a lot of them.
A bumper crop, as they say.
2 classes worth.
Nice.
Yeah.
All right. Well, as always, thank you all so much for joining us. And if you have any ideas for future meetings, be sure to reach out and let me know. And I hope you all have a great start to summer. Thanks, everyone.
Thanks to
Thank
all.
you.
Thanks, everyone. Take care.
Thank you.
Thank you.